So basically the presentation is about how to optimize the sequence in HER2 positive metastatic breast cancer. And I think it's quite easy to see that we have a clear sequence to treat our patients when they have HER2 positive metastatic breast cancer. I think that the role of pertuzumab and trastuzumab based therapy in the first line setting is very well established. And maybe the key point is how to treat our patients afterwards. We have great data with T-DM1 showing a clear advantage when it has been compared with lapatinib and CAPE. But also we have the Theresa trial, which compared T-DM1 versus physician's choice. Both trials were absolutely positive for the primary endpoints, progression-free survival and overall survival. And from my point of view, we have to understand that the earlier, the better. That is why I think that T-DM1 or Kadcyla should be used as soon as possible in those patients who are resistant or refractory to trastuzumab and taxane-based therapy. That's why, in my opinion, and this is what we have discussed, is the first-line setting should be pertuzumab and trastuzumab-based therapy, followed by T-DM1. Well, unfortunately, not all patients are treated the same. Of course, there are many issues to be considered. But again, if possible, I think this sequence is quite clear, or should be quite clear, for treating the majority of our patients. Of course, not for all of them, but for the great majority, I would say maybe for 90 or 95% of them at least. I think that this is a very reasonable sequence. I have been talking also about brain metastasis from HER2 positive breast cancer. And I think that here, and again, this is my opinion, we should not change the way we treat our patients. I think that pertuzumab-based therapy should be also the standard of care in the first-line setting, followed by T-DM1. So in my opinion, brain metastasis should not change the sequence of treating our patients. Well, you're right. I think that when we are facing patients with brain metastasis from breast cancer, some of our colleagues believe that other sequence could be even a better approach, something like about lapatinib plus something. I think it's a good approach as well, but we should not forget the data we have from the Emilia, in which those patients who had non-progressing brain metastasis had an overall survival benefit if they were treated with T-DM1 compared with lapatinib-based therapy. So again, that's why I think that T-DM1 is also the preferable option in the second-line setting if the patients have brain metastasis. It would be great to have some trials for brain metastasis from breast cancer. To the best of my knowledge, we do not have that many. We have some trials with tucatinib, which is a new tyrosine kinase inhibitor, and also we have some trials with a new chemotherapeutic compound called irinotecan for patients with stable, non-progressing brain metastasis. So we also had a great debate with Hope Ruo, trying to discuss which is the optimal treatment for early breast cancer. So should we combine trastuzumab and pertuzumab for early breast cancer, HER2 positive early breast cancer patients, or can we go for Herceptin only? I think this is a great debate. I think that this is not as easy as in the metastatic disease, but in my opinion, at least for patients with ER negative and or node positive tumors, trastuzumab and pertuzumab should be clearly discussed and clearly at least offered. And the reason is very simple. The hazard ratio is below 0.80, in the range of 0.77 or 0.76. The absolute improvement at 4 years is in the range of 3% for this group of patients. And I'm pretty sure that with the long-term follow-up, we'll see higher absolute benefits. So again, for this group of patients, ER negative and or not positive, in my opinion, pertuzumab and trastuzumab should be considered for the majority of our patients.